presenting October 2022 practice question. Question 2A. I'm Dr. Melanie Nwabweze. A 60-year-old man presents with a 2-day history of dysphagia and a day history of shortness of breath and lip swelling. He is on medication for hypertension, pain, and CA of the prostate. He had an antihypertensive added to his medication prior to onset. Picture of swollen lips shown. The first question is, what is their diagnosis? The B question is, mention 2 classes of drug associated with this condition. The C question is, discuss step-by-step management of your diagnosis. This is the picture. Then my diagnosis is drug-induced angioedema. I made this diagnosis because, first, these patients presented with dysphagia and history of shortness of breath. In angioedema, when it affects the respiratory tract and the GIT, one can present with this shortness of breath and dysphagia. And secondly, this patient has been on antihypertensive medications and drugs for pain and CA, had no problem. But as soon as a new drug was added, antihypertensive drug was added, he developed all these symptoms. So I'm thinking that what must have caused this may be ACE inhibitor, since it's the most likely drug being used in antihypertensive medications. And also a history of swollen lips. That's also how angioedema used to present. So mention 4 classes of drugs associated with this condition. The 4 classes of drugs include angiotensin converting enzyme inhibitors like lisinopril, ramipril, captopril, and enalapril. Angiotensin receptor blockers, example, losartan, cadarsatan, and valsartan. Non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, diclofenac. Renin inhibitors, example, ariscarin. Also the BPPV inhibitors, example of which is sitagliptin, vidagliptin, linagliptin. Others
Dr. Melanie, can you put it on the slideshow?
Oh, we did go back to. Okay. Sorry, let me look for my poster. Okay. Oh,
okay,
sorry
that's
about
fine.
that.
No problem.
The blocking drugs and the iodinated contrast media. For the step-to-step management of the diagnosis, I want to state that it's a medical emergency, and the aim is to maintain a patent airway, relieve symptoms, stop disease progression. The management is basically multidisciplinary and includes the ENT surgeons, clinical pharmacologists, clinical immunologists, and critical care physician. The patients must be managed in ICU in severe cases, because most times this angioedema usually progress from being from angioedema to anaphylaxis. So nobody knows how it will end up being. Then a quick history and physical examination is very important. It's good to know whether there is a previous past history of these symptoms, whether there is a family history of RA genes, history of dysphagia, dyspnea, nausea and vomiting. The offending agent, like in our index patient, is the ACE inhibitor that I'm suspecting. Then also on examination, the swelling of the face, the tongue, the genitalium also is very important to note. Then when the offending drug is found, the first thing is to discontinue the offending drugs. Then the ABCD of resuscitation will be instituted. The oropharyngeal airway will be inserted. Then the airway management, urgent thyroidectomy is very important in these patients, or tracheotomy, especially in a patient that has severe laryngeal edema or airway obstruction. It's also good to commence intravenous volume expansion with crystalloid, 0.9% saline using a wide bore cannula. It's good to monitor. I'm going to monitor the vital signs, street input and output charts to be kept, and to put prompt administration of IM or subacute adrenaline. The dose of 0.01 per kg, maximum of 0.5 milligram of 1 in 1,000 formulation. The site of administration is mid-outer thigh. The dose may be repeated at 5 to 15 minutes if no response. IV adrenaline continuous infusion at 0.1 per kg per minute if no or inadequate response to repeated IM administration. The adjunct medication includes IV glucocorticoids and can be used. IV glucocorticoid is used in severe symptoms or a patient that is known to have asthma. And he said that it induces the expression of ACE and accelerates bradykinin metabolism and alleviates the angioedema that is mediated by bradykinins. Also, the antihistamines, even though the pathophysiology does not show that it's histamine mediated, but most times, and some studies, they also use the antihistamine. The antihistamine 1, citrazine, can also be used. The diphenylhydramine, IV 25 to 50 milligram over 5 minutes. It's usually combined with the histamine 2 antihistamines. The example of which is famotidine, the dose of which is 20 milligram over 1 to 2 minutes. Bronchodilators are also used, especially when there is bronchospasm. In this, our patient has a difficulty in breathing, so we are not out of place if we consider this salbutamol nebulizer. Then oxygen, if patient is in respiratory distress or desaturating. Thank you.
Okay, thank you, Dr. Melanie, for answering the question. It's time for contribution, questions, clarification. Even though, did you add? Oh, okay. You had some slides for angioedema because I wanted to.
Yes.
Ask. Okay. Is there any highlights you want to give us on those slides? Important highlights, not reading out the whole of the slide. Is there any important highlights you want to tell us?
Nothing in particular, just to explain what angioedema is.
Okay, can you give us a brief pathophysiology of angioedema, and then so that we give
I talked about the ACE. Since I'm thinking my diagnosis is ACE, ACI, that is angiotensin converting enzyme induced angioedema. So it's one of the leading cause of angioedema, and it's due to inhibition of bradykinin degradation. Yes, you know, the ACE helps in the conversion of angiotensin 1 to angiotensin 2, and also the breakdown of bradykinins to other metabolites. When there is accumulation of these bradykinins, it causes vasodilatation and also extravascular fluid penetration, leading to edema and angioedema that is seen in angioedema. As most people on ACE inhibitors are able to normalize their bradykinins level by other pathways, a genetic susceptibility is assumed. However, histamine is not involved. Like I said before, histamine is not involved in the pathogenesis or pathophysiology of this drug-induced angioedema. The ribs are mostly affected and is not usually accompanied by urticaria. And it occurs within 1 week to few months of initiating ACE inhibitors, but it may occur several years after starting. So just like I explained, the ACE is angiotensin converting agent enzyme. It converts angiotensin 1 to angiotensin 2. That process is inhibited when there is the ACE inhibitor present. And also the conversion of bradykinin is not metabolized, so it accumulates. From these bradykinins, it will not be degraded, so it accumulates and causes the edema seen in angioedema, and so on. That's
okay,
what
thank
I
you.
was able to. Yes, sir.
Okay, thank you. So let's quickly make our contributions. Questions, clarifications can be made so that we can move. So Dr. Emmanuel say thank you for your presentation. Dr. Feisara say thank you for your presentation. Apart from hypotension, shock, are there some other features that help to differentiate anaphylaxis from angioedema? This patient has shortness of breath and dysphagia. So can you differentiate anaphylaxis from angioedema? I think that's the question Dr. Fei is asking. So you can go ahead and answer.
The angioedema is usually localized, while anaphylactic or anaphylactic shock is usually generalized. Apart from causing, it can cause hypotension, it can cause even renal impairments, and can affect every other system. I know it can cause, I don't know very well, I'm not too sure, but I think it can also cause hypoxic encephalopathy or something like that. I don't know I'm not too sure. But I'm sure of the shock and hypotension and reduces the renal perfusion, causing maybe acute renal failure. I'm not sure of any other, but I know that it's generalized, unlike in angioedema that affects a particular place, can affect the lips or genitalia or every other part of the body. Tongue can be swollen. Yes, sir.
Okay, so you say, okay. Any other? Why is there initial adrenaline dose given IM? So Dr. Adebimpe is asking.
Adrenaline is the drug of choice being given in angioedema. It is said is mainly because of the respiratory, it has to do with the respiration. I think it's the vasoconstriction or bronchial constriction. That's why it is the drug of choice for a patient that has angioedema.
Okay. Is there any other contribution before any other contribution? Any other? You can raise your hand electronically and speak if you want to make contributions. While we're waiting for contributions, can you unshare your slide? Can someone help us share Dr. Afolabi's slide? It's on the chat group, and he just dropped it this morning on the chat group. So can we help him share those slides that while we are waiting for more contributions? We can take the next question.
Dr. Wambele did well. So thank you so much, Dr. Wambele. Thank you. I think we can move over just to save our time. Let's move on to the next presenter.
Good morning,
Dr. Charles. Yeah.
Yes,
okay.
Yes. Please, sir, can I go ahead?
Okay, you're the one sharing.
Yes, sir.
Okay. All right, fine. Dr. Afolabi, just give us some minutes. Let him finish. All right, Dr. Charles, you can go ahead.
That's not my question, please. Thank you.
Yes, yes. I think Dr. Charles has shared his own slide before someone helped you to.
All right, thank you, sir.
So maybe we'll just give Dr. Charles the opportunity to just go ahead. So you can go ahead. You have 15 minutes. And before you just go ahead, Dr. Jafar say ACE, angioedema don't respond well to epinephrine and histamine and steroids. So just for us to note. Okay. So go ahead, Dr. Charles.
Okay. Good morning, our teachers, all the fellows present, and my colleagues. I'll be presenting practice question 1A, October 2022 General Medicine Recall. Please, I don't know if I'm quite audible.
Yeah, you're audible.
Okay. All right. So the question is: a 45-year-old male presents with a 9-year history of G6PD deficiency and hepatitis C, presents with fever and a new parasternal murmur. Blood culture grew Staphylococcus aureus, echo revealed vegetations on the blood, and urea and creatinine were elevated. Okay. And urea and creatinine were elevated. What questions will you like to ask him? What is a likely diagnosis? Mention other relevant investigation. Mention 5 other complications of this disease. Outline your management plan. How will you prevent this condition? Okay, So we have a history of a 45-year-old man. The salient things in the history are that echo revealed that he has a vegetation on the aortic valve. Okay, then also blood culture was positive for Staph aureus. Okay, so with that, our diagnosis is likely infective endocarditis. Other relevant questions we want to know is if he has other risk factors that puts him at risk for infective endocarditis. Something like, does he have renal disease? Does he have central catheters? Maybe a central line? And is he on hemodialysis? Does he have a history HIV drug abuse? Okay. Does he have a history of a cardiac implantable electronic device, pacemakers? Does he have poor dentition? How is his dentition? Does he have poor dentition or any dental infection, dental abscess that may put him at risk? Does he have other symptoms of infective endocarditis? Does he have skin manifestation? Does he have splinter hemorrhages, petechia, osseous nodes, Jenway lesions? Is he immunodeficient? That may also put him at risk of infective endocarditis. Is he diabetic? Is he also, in addition to what we have been given, is he also diabetic? Okay, then other constitutional symptoms like fever, anorexia, weight loss. Okay, does he also have other constitutional symptoms that may also tell us that it's possible that he may be infective endocarditis? Okay, so what's the likely diagnosis? The likely diagnosis is acute bacterial endocarditis because of the classical history, the new momo. Okay, then because of the classical history, the new moment, of course, the echo findings of vegetation on the aortic valve and confirmed with blood culture that grew a typical organism that is capable of causing endocarditis, that's Staph aureus. Of course, this diagnosis is gotten by the Duke's criteria, okay, which has some things that we need to know. Okay, when the blood culture isolates a typical bacteria or there's persistent bacteremia, then with echo findings with other clinical and laboratory findings. Okay, so this table just tries to tell us the modified Duke criteria that has major and minor criteria. Of course, the major criteria include two basic things: positive blood culture and endocardial involvement. Positive blood culture involves isolating a typical organism from at least two cultures, okay? Then persistently positive blood cultures, if they are taken more than 12 hours apart, then 3 or more positive cultures taken over more than 1 hour apart. Then endocardial involvement involves a new valvular regurgitation or positive echo findings of vegetations. And the minor criteria, if there's any predisposing valvular or cardiac abnormality, valvular heart disease, mitral valve prolapse, aortic stenosis, mitral regurgitation, all those things are predisposed. Even congenital heart disease, GSDs, ASDs, predisposing valvular or cardiac abnormalities that may predispose to infective endocarditis. Is there intravenous drug abuse, fever more than 38 degrees, especially have embolic phenomenon, okay, stroke, splenic infarction, mesenteric ischemia? Does the patient have any vasculitic or immunologic phenomenon, okay, like the rod spot, Jenway lesions, and all that? Then blood cultures that are suggestive of infective endocarditis but do not achieve the major criteria is also a minor criteria. Then suggestive echo findings that doesn't meet the major criteria is also a minor criteria. So to make a diagnosis from the Duke's criteria, you need 2 major, or you need 1 major and 3 minor, or you need 5 minor. So if we have possible IE, that for Dukes, for IE, you can have definite, possible, or rejected. Definite is what I talked about earlier. Then possible is you have 1 major and 1 minor. 1 major and 1 minor, you have 3 minor. Then rejected is when you have a firm alternative diagnosis or the symptoms resolve within 4 days, which is not likely if it's infective endocarditis. So I've talked about, this is the table trying to explain what I talked about. The next question is mention other relevant investigation. Of course, we've already been told that the patient has done blood culture and has done a transthoracic echo. Okay, so we won't have to mention that again. So other investigations we need to talk about include a full blood count, which may show neutrophilic leukocytosis. Okay. hardening if, like our patients, they already gave us that too. So it's also important we know that the liver function test may show the liver enzymes, especially the alkaline phosphatase and gamma GT, which may be elevated. Urinalysis may show blood microscopic hematuria, okay, may be seen in the urine. Then ECG, although ECG may be normal, but we may see evidence of conduction disturbances such as a high-grade AV block. Okay, then transesophageal echo is also important. Transesophageal echo is very important if our transthoracic echo is either non-diagnostic or not certain. It's either non-diagnostic or not certain. We can consider doing a transesophageal echo. Then other inflammatory markers such as the ESR and the CRP may be elevated. Then chest X-ray. Chest X-ray may be normal, but if the patient presents in heart failure, we may see signs of heart failure on chest X-ray. So mention 5 complications of the disease. Of course, the first complication is heart failure. They may also have an abscess. This is a patient that is presenting with aortic valve endocarditis, may have an aortic root abscess. Okay, the infection can also spread to the myocardium or the pericardium and cause myocarditis or pericarditis. Okay, the vegetations can also embolize. Since we are looking at an aortic valve endocarditis, we'll be looking at systemic emboli. It can go to the brain and cause a stroke. It can go to the abdomen, causing mesenteric ischemia, splenic infarction, and all that. Okay, then arrhythmias. Okay, you can have heart rhythm abnormalities depending on the location. Like, for example, this patient that has aortic valve endocarditis, if it affects the AV node, it can cause an AV block. So it's also a possibility. Then you can also have infectious aneurysm, mycotic aneurysm, if it spreads into the blood vessel, causing dilatation of the blood vessel wall, which can even lead to rupture. Okay, so outline your management plan. The first thing in management is to know that infective endocarditis management is multidisciplinary. Okay, and it will involve a team of cardiologists, cardiac surgeons, infectious disease specialists, microbiologists, then depending on complications, neurologists, neurosurgeons, nephrologists, okay, experts in congenital heart diseases, depending on what exactly the patient is presenting with. The goal of management is to give antibiotics and sterilize the vegetations with antibiotics. The antibiotics are usually given for a prolonged period, minimum of 4 to 6 weeks. Okay, and it's antibiotics that are bactericidal that are being advocated for. Then there's also a room for surgery if indicated, which I will also talk about. Okay, so for this patient that has staphylococcal endocarditis, want to use flucloxacillin. That's the drug of choice. Flucloxacillin is a native valve endocarditis. We'll have to get that from the history. Okay, flucloxacillin with or without an aminoglycoside. You can also use vancomycin with or without aminoglycoside or rifampicin. Patients with prosthetic valve endocarditis, we use flucloxacillin and aminoglycoside and rifampicin. We could also use the other alternative as seen there. So indications for surgery, including the patient has congestive cardiac failure, patient has perivalvular invasive disease, the person has uncontrolled infection. Despite maximum antibiotic therapy, infection is still uncontrolled. It will tell you that there may be an abscess somewhere that you may need to surgically remove. If the person has prosthetic valve endocarditis, okay, if the person conduction deficiency like heart block, okay, is also. How will you prevent this? Of course, preventing endocarditis is very important, and that's why it was instituted that antibiotic prophylaxis should be used. Antibiotic prophylaxis should be given, especially when performing high-risk procedures in patients who are at risk. In the initial time, antibiotic prophylaxis was given for virtually anybody who was going for either a respiratory tract, gastrointestinal manipulation, or maybe things like endoscopy, bronchoscopy. In the recent guidelines, it's no more advocated that antibiotic prophylaxis should be given for such. Antibiotic prophylaxis should be given for things for procedures that have that will involve a gingival
manipulation. Okay, then also patients with high risk conditions like as listed, people with prosthetic heart valves, including bioprosthetic and mechanical valves. People with a previous history of infective endocarditis should also receive these are the highest rates of they should receive prophylaxis when going for this highest rate of procedure. That is dental procedures that involve manipulation of gingival tissue of the teeth. Okay, then no, like I said, no prophylaxis is required for maybe respiratory bronchoscopy procedures that affect the respiratory mucosa or GI or genitourinary system. All these patients, maybe who are going for endoscopy, they will not need prophylaxis. Okay. All right, so these are the regimen for prophylaxis, for antibiotic prophylaxis. Standard oral regimen will include amoxicillin 2 grams 1 hour before the procedure. If the person cannot take oral, you can use ampicillin 2 gram IV or IM within 1 hour. If the person is allergic to penicillin, you can use clarithromycin or azithromycin. If the person is allergic and unable to take oral, you can use cefazolin, ceftriaxone, or clindamycin.
Just for the just give us highlights. I know you've mentioned most of it, but is there any highlights you want to give us from the presentation?
Okay. So
just highlights only, maybe in the next 2-3 minutes.
Infective endocarditis is simply infection of the endocardial surface of the heart, and it may affect one or more of the heart valves. So it could be acute versus subacute, culture positive versus culture negative. It could be right-sided or left-sided. It could be nosocomial or community acquired, and it could be native valve. Of course, native valve means that it's affecting the valve, the valve, or it could also be prosthetic valve. Infective endocarditis is seen more commonly in prosthetic valve. Okay, so these are the risk factors for native valve endocarditis: rheumatic valvular heart disease, congenital heart disease, mitral valve prolapse, degenerative valve diseases like calcific aortic stenosis, or even bicuspid aortic valve. Okay. Then intravenous drug abuse is also a risk factor. Then culture negative IE has some risk factors. For example, who have had antibiotic use. Then some fastidious organisms. Of note is it has set group of organisms. Then Coxiella bonnetti, Bartonella, and chlamydia. Fungal endocarditis is also a cause of. So this is important. What are the risk factors? So the most significant risk factor is residual valvular damage caused by previous attack of endocarditis. Okay, then you could also have, there could also be intravenous drug abuse, like we said, prosthetic heart valve, structural heart disease. Okay. Then there are also some host factors, things like neutropenia, immunodeficiency, malignancy, diabetes, and intravenous drug abuse. So this divides the risk factors into cardiac and non-cardiac risk factors. So endocarditis is usually a consequence of two factors: the presence of organisms in the bloodstream and abnormal cardiac endothelium, which facilitates their growth and adherence. So all these things will eventually lead to bacteremia. Then how would they present? Their symptoms are commonly vague. They usually start with conditional symptoms: fever, chills, anorexia, weight loss, malaise, headache, myalgia, night sweats. Then as it progresses, they have shortness of breath, cough, joint pains. Okay, then other things they may present with include clubbing. It's important to know that a new or changing murmur is a very important feature of endocarditis. Okay, they may also present in heart failure. Then other clinical presentation, they may have ulnar nodes, splinter hemorrhages. These are immunologic phenomena. They may have Janeway lesions and also petechia. In the eyes, they may have rod spots and conjunctival splinter hemorrhage. They may also have complications depending on how the emboli goes: splenomegaly. Neurological complications include cerebral embolism, mycotic aneurysm. They may also have hematuria. Okay. How do we diagnose IE? Of course, important is blood culture and echo. Then other things include ECG. Then, of course, we talked about the Duke's criteria. Okay, transthoracic echo is first line if IE is suspected. Okay, then transesophageal echo will have better delineation. Okay, it's also important in assessing prosthetic valves, assessing complications. So if the transthoracic can be inadequate for various reasons, obesities, emphysema, and all that. Sometimes because the vegetation, because infective endocarditis is not actually the only cause of vegetation. The vegetation may be so small and you are not certain, is it oscillating, is it not oscillating? So those are times where you may need to go and do transesophageal. Okay, then we've talked about the Duke's criteria, both the major and minor. Talked about how to classify it into definite, possible, and rejected. Okay, then this just an image of splinter hemorrhages is usually non-specific, but it's non-blanching. Know that it's linear. The lesions are linear reddish brown. They are found under the nail bed and they do not extend to the entire length of the nail. Osler nodes are painful, unlike Janeway lesions that are painless. They are located on the pulp of the fingers and the toes. They are more common in subacute IE. Rod spot is a pale area seen in the retina on fundoscope. Rod spots. Okay, so how do you treat? The major goals of treatment is you want to eradicate the infection, you want to address complications, you want to treat heart failure. General measures, you want to treat heart failure, give oxygen if indicated, if hemodialysis, if also indicated. Of course, antibiotics is the mainstay of treatment. Antibiotics should be tailored according to sensitivity, but could be started empirically depending on suspicion. Antibiotics are typically continued for a long time, classically 4 to 6 weeks. Okay, then surgical intervention should be considered if there's extensive damage to the valve, if there's prosthetic valve endocarditis, where you need to actually replace the valve, if there's persistent fever, that indicates persistent infection, if vegetations are large, and if there's serious embolization, because it may actually happen again. Okay, so these are the members of the heart valve team that I talked about. So monitoring, you should monitor. Okay, monitor blood cultures should be taken after 3 to 4 days to document eradication of bacteremia. If fever still persists more than 10 days, an indication that you should look for complications. Okay, so these are the complications, we mentioned them earlier. So prevention is key. Like ESC recommends antimicrobial prophylaxis for patients at high risk of an adverse outcome from infective endocarditis. So we've talked about this, any procedure involving manipulation of gingival tissue or the periapical region of the teeth, any procedure that involves incision of the respiratory. So these are things that will need prophylaxis. Okay. So prognosis, they are independent predictors of mortality, which includes higher age, elderly persons, Staph aureus infection, heart failure, then embolism. Thank you very much. Thank you.
Yeah, thank you very much, Dr. Afolabi, for a wonderful presentation. So do we have any comments, any contributions?
Dr. I'm done.
Yes, I can hear you. Yes, I thank you for your presentation. Okay. All right, Dr. Ibe is saying, thanks for a beautiful presentation. What about the GCSPD deficiency and hepatitis C virus infection mentioned in the question? Yeah, you didn't say anything about it, Dr. Michael. And then Dr. Temi is saying, will this patient benefit from OPAT?
From what, please? I didn't hear you.
OPAT. Dr. Adeyanju, what's OPAT? Give us a full minute so that he can get it. So you didn't mention the Hep C glucose 6 GCSPD deficiency. You didn't say anything about it in your presentation. Can you hear me, Dr.?
I can hear you. I can hear you. I can hear you.
Yeah. So,
Actually,
so Dr. Chika is here.
Okay.
You can go ahead.
Okay. Actually, I was not certain why G6PD deficiency and Hep C, although one of the risk factors for IE is immunosuppression. Okay, but I don't consider Hep C. G6PD may be because of hemolysis. Okay, worsening the hemolysis. They're already prone to hemolysis. Okay, but I was not actually certain why it was there in the question, so I took it as a distractor. Maybe I can be corrected if I'm wrong.
What of okay? What of the Hep C?
The same thing too with the Hep C. I was not, because I didn't see Hep C as a risk factor for infective endocarditis, except if you link it with intravenous drug use. Okay, because if somebody is sharing needles, it puts the person at risk of Hep C. But apart from that, I didn't see Hep C as a risk factor for infective endocarditis.
Okay, the
I
OPA.
think basically, I think
Yeah.
basically they're just trying to tell us that probably this patient got it from IV drug use. You get, so I think that's why, that's like a pointer in the question. So you made mention of IV drug users can actually be predisposed to infective endocarditis. So I think it's a pointer towards there that probably he must have gotten it from IV drug use. So it's not really like I think it's giving you it's taking you somewhere. It's giving you a history. Mm.
Okay, yeah. I think that's that for hepatitis C. Okay, yeah, it to give you a clue that okay, probably from IV drug user. But again, as part of your management, also you have to do something about the hepatitis C, because it needs also to be treated as part of the management of this patient.
Okay, sorry. And in IV drug users, the right-sided valves are more affected as compared to the left. So it's actually very useful. The history is useful. The right-sided valves are more affected as compared to the left in IV drug users. So it's not like a history that should be thrown away. Thank you.
Yeah. Thank you very much. And also the G6PD deficiency, I think it has something to do with cardiac remodeling in this kind of instance. Probably maybe we need a cardiologist to help us fine tune that. Dr. Temi was saying outpatient parenteral antibiotic therapy. Is there any benefit from outpatient parenteral antibiotic therapy?
Well, okay. The treatment duration for infective endocarditis is usually 4 to 6 weeks. Okay, some people say that you can give IV for about 2 to 4 weeks, then complete with outpatient parenteral. You can complete with outpatient oral. Okay, she's actually asking for outpatient parenteral.
Yes.
Okay. I'm not certain about outpatient parenteral. I'll have to check it out. I'm not certain about, but what I saw is that you can actually start with intravenous, then for the last 2 weeks you can actually complete with oral. But I'm not sure about outpatient parenteral. I'm not certain.
Okay, Dr. Semi, you can go ahead.
Thank you very much, sir. Good morning to our mentors, consultants, and everyone on the platform. Thank you, Dr. Charles, for your presentation. Now, outpatient parenteral antibiotic therapy is one thing that they've been pushing for the last 5 years. Although there are countries that have been doing that, and what brought that up was because of economic benefit that they've seen, and to reduce in-hospital stays so that patients will not have additional nosocomial infection. And there are criteria for giving patients OPAT, for giving them OPAT if they have IE. One of the things is that the infection must not be Staph aureus related. Apart from that, it must be a native valve endocarditis, and patients must have been stable before commencing OPAT. So they first do an inpatient, then translate to an outpatient. For the inpatients, 1 to 2 weeks of intensive IV antibiotics. Then outpatients, they will already have a control program and protocol in which they have nurses that are dedicated to giving the patient that will come from home daily to get the required IV antibiotics, and they will go home. So they select their patients carefully. They are stable from the ward already. They are native valve. They are not staphylococcus infected IE. Also, apart from that, all the contraindications that you've listed earlier, they are also taken into place. That means that if the vegetation is greater than 10 mm, they may not be suitable for OPAT. But the whole goal of OPAT is to because of the cost benefit of OPAT, and also to limit nosocomial infection. So I think these patients can benefit from OPAT, and it's something that we should all know about because they are now really talking about it. And a proposed guideline has also been made by the ESA, but it's not yet in the guideline. Thank you very much.
Okay, yeah, thank you, Dr. Temi, for that clarification. Dr. Charles, can you unshare your slide so that we can share Dr. Afolabi's slide? Any other contribution while we're trying to share the slide for the next presenter?
Hello, good morning.
Yeah, good morning. Okay, Dr. Yusuf.
Yeah, thank you. Please, for this OPAT that we are talking about now, does that mean the patient will now have to take the outpatient parenteral for the rest of the 4 weeks? Because from the last presenters, the last speaker said the inpatient antibiotics, IV parenteral antibiotics will be for 2 weeks. Now, does that mean the outpatient will be for the entire 4 weeks? Or is there at any point in time will the patient will be switched to oral antibiotics? Thank you for the open. Yes.
Dr. Asa, I don't know whether you can go ahead and answer.
You see?
I don't know whether I can go ahead and answer.
Okay, what Dr. Yusuf is saying?
Yes, please.
Okay, well, from what she said is, if we want to go for the upper, then what it simply means is that you can actually go for that duration of time, that duration of at least 4 weeks of IV antibiotics. The idea is to reduce hospital stay, and then of course you need to also fulfill those conditions for you to get. So yeah, it's something, even though, well, we have not started practicing it, but it's something that has been, so the IV will be for the rest of the duration. So if you have given for 2 weeks, then you also need to complete maybe for another 2 weeks if you are targeting a 4-week duration therapy for the patient. All right. Somebody is raising. Okay. Dr. Dalhatu, you want to say something? Can someone help us share Dr. Michael's slides, please, from the chat box?
Nothing.
So that I'll be able to.
The presentation. This category of patients, they are the one that we should be careful for practicing OPAT in them. One is highly virulent organism, Staphylococcus aureus, and also this is a patient with suspected drug abuse. So if we are to give him OPAT, we may put him at more risk because he has an IV access. He will just continue to use his drug abuse. So I think these are some of the category of patients that we may not want to practice OPAT in them. Thank you very much.
Yeah, thank you, Dr. Dalhatu. Yeah. So there are indications for starting OPAT from what Dr. Temi is saying. So we have to fulfill those conditions for you to prescribe OPAT for any patient. Are we finding it difficult to, okay, let me see if I can. Okay. Dr. Afolabi.
Yes. Morning, sir.
Let's see if we can share. I'm trying to see if I can help him share the slide. Can you see my slides? Can you see it?
No.
Okay, let me try.
Okay.
Thank you.
Please, can you see the screen? Professor?
Okay, I'm coming. Okay, yes, we can see the screen now. Yeah, we can see your screen. Yeah, we can see your screen, but we have not seen the presentation yet. Okay. Yeah, that's good.
All right.
All right, thank you very much for helping out.
All right.
So, Dr. Afolabi.
Good morning, consultant and senior registrar. Thank you for the opportunity, Sir Sama. We'll be presenting practice question 3A, October 2022. And the question says, a 60-year-old female with recent onset dizziness, notice on standing from the bed or sudden turning of the head to the side. She's not a known hypertensive or diabetic. She's afraid she has a brain tumor. The first question says, list 5 differential diagnoses. What is the most likely diagnosis? The second question says, what would be your finding on clinical examination? How will you investigate this patient? She's scared of leaving the clinic. How will you manage and advise the patient? The differential diagnosis in this patient will include the benign paroxysmal positional vertigo, BPPV. The second differential includes vertebral-basilar insufficiency, mania disease, labyrinthitis, orthostatic hypotension, carotid sinus hyperactivity, and vestibular migraine. These are the differentials that could be entertained in this patient. The next question says, what is the most likely diagnosis? The most likely diagnosis in this patient is benign paroxysmal positional vertigo. Why did I entertain that possibility? Because one, it's commoner in female, usually above 60 years and above. And this patient presented on account of recent onset dizziness, and I was noticed on standing from the bed and while turning the head. This is the reason why I'm entertaining the possibility of benign paroxysmal positional vertigo in this patient. The next question says, what will be your finding on clinical examination? These patients could have nystagmus, could have vertigo, and on examination. And apart from that, there could be a sudden drop in the blood pressure, systolic blood pressure of greater than or equal to 20 millimeter of mercury, or diastolic blood pressure of greater than or equal to 10 within 3 minutes of standing, which could suggestive of postural hypotension. These are the clinical signs that can be seen in this patient. How will you investigate? The investigation in this patient can be divided into specific investigation and general investigation. The specific investigation that should be done in this patient include this all-pipe maneuver, which is actually the standard clinical test that should be done in a patient with benign paroxysmal positional vertigo. And it's performed by moving the patient from a sitting position to a spine position while turning the head 45 degrees to the right. And the test should not actually be done while the patient lie down overhanging the edge of the bed and look. One should look for nystagmus. And apart from that, the test should also be repeated on the contralateral side if nystagmus is absent on the first side that was tested. So there's an image there demonstrating how this all-pack maneuver could be done. The other tests that can also be done in this patient will include row test or row maneuver, and it's similar to this all-pack maneuver. So the patient should be examined in supine position with the head 30 degrees up, or while the examiner quickly rotate the head 90 degrees to the left and check for vertigo and nystagmus. It's also an important test, although the standard test that should be done is this all-pack maneuver. And we can see a pictogram here, an image here demonstrating how it can be done. The other investigation that can be done will include an audiometry, which one could check for an audiogram, which could suggest if there are presence of any hair abnormality. Other specific investigation that could be carried out in this patient include electronystagmography or video nystagmography to check for the presence of nystagmus. Echocardiography can be ECG, echocardiography can be done if there are, because arrhythmia could also presents with patient could present with vertigo, could have all these, could have the symptoms. Brain MRI is not routinely requested. However, if the patient presented with weight loss, early morning vomiting, recurrent headache that's suggestive of space occupying lesion, a brain MRI is an important investigation. Then general investigation will include a full blood count, check for anemia, check if there, because this patient could have inner ear infection. Full blood count is important. Then CRP, just is an inflammatory marker to be raised. Full blood count to our prophylaxia will also be done because one is suspecting diabetic autonomic dysfunction. Here and you, calcium play an important role in the formation of calcium carbonate, which is present in the autolytic organ. And disturbance of this could actually affect the airing, affect airing and balance. And this patient could manifest with those symptoms that was previously asked. Fasting lipid profile, abnormality of the lipids could also affect blood vessel that supplies the inner ear and could actually affect hearing as well and lead to hearing abnormality. Thyroid function test, hypothyroidism, and it can also present with pictures of vertigo, generalized body weakness. The scale of leaving the clinic, how will you manage? The principle of management in this patient is, first of all, to confirm diagnosis and rule out differentials. And apart from that, patient education play an important role here. And it depends on the etiology, history, and the clinical examination. And this patient should be advised based on the clinical parameters. And multidisciplinary approach is very important. ENT surgeon, neurology, nurses, pharmacists will also play an important role in the management. Lifestyle modification, patients should be advised to avoid sudden head movement, tilting the head backward, sleeping on the affected side, or rolling over quickly in bed. Then other activities that should be avoided include activities that involve rapid head movement, like dancing, like operating heavy machine, and patients should be advised to stepwise rise from the lying position. The treatment modalities is actually the use of Epley or Simons maneuver. So thank you very much. I don't know if I can still go ahead because of time. It's already 8 o'clock.
Yeah, thank you very much for the presentation. So you will go, since you've dropped the slide in the, so people get familiar with your slide. So if there's any contribution we can make, the time is fast spent. Okay, Dr. Success, you can go ahead.
Okay, good morning, teachers and colleagues. I just wanted to say briefly that PPPV is an example of a peripheral vertigo. Okay, so, and we have other types of peripheral vertigos like labyrinthitis, Meniere's disease, and so on. One of the ways we can differentiate between PPPV and Meniere's disease, for instance, is Meniere's disease will come with things like hearing loss, sensorineural hearing loss, and also vertigo, unlike PPPV. Now, there's a diagram I was supposed to share. I think he also gave us that diagram where we'll see those semilunar canals. The summary of PPPV is that what is the writing is being displaced to be in the wrong place. What does that mean? Okay, so those otolis that usually are supposed to be in the utricle, they dislodge to the circular canal, and that is where the trouble starts, and begin to irritate it, and then the head begins to, that's how vertigo starts, when there's a wrong signal sent to the brain. It's important to also note that the most common PPPV is the posterior canal, and that is the one we use the Epley's this Hallpike maneuver for, okay, and of course Epley's maneuver for management. I also want to say that sometimes too, it's important for us to note the difference between a central and a peripheral nystagmus. So in these patients, you want to know, are we dealing with a central, are we dealing with a peripheral, and what are the subtle differences? Now, when this patient has something like, of course, this patient has a peripheral nystagmus, and so we expect that it should be fatiguing, there should be latency, and of course it should be suppressed by visual stimuli. These are the and also the duration will be less than 1 minute. These are the features we see in patients that have peripheral nystagmus. So that's what I just briefly have to say. Let's note that the semilunar canals are very important for the angular notions of the head. Thank you so much.
Thank you very much, Dr. Success, for a wonderful contribution. Any other contributions? Okay, Dr. Adebimpe is saying, thanks for the presentation. Orthostatic hypotension is not a feature of BPPV. Any other contribution before we hand over to our teachers? Okay, Dr. Christopher. Wow.
Hello, Dr. Atta. Thank you for anchoring. Thank you so much. Thank you. I want to appreciate the three speakers this morning, Dr. Wambweze, Dr. Corey, and Dr. Afolabi. Thank you. Thank you. I'm happy that we did 3 questions today. If we continue at this pace, the exam is next month. I know February is like half month. We're almost today, I think it's 20th or so. Well, we're already in March. And one thing I know is that what we usually do, we do recalls, then we start attempting some tropical questions. Because one thing with dermatology, they try not to repeat questions. If you have been following the practice questions, you realize that dermatology doesn't repeat questions. They have time for you. And dermatology is so wide. So dermatology is so wide, so they can always come up with another question. So what we'll do after we're done with some recalls, we start going around tropical questions, trying to see, okay, anything happening currently that we can quickly talk on. So we try to do this just before the participants go for their exam, so that we can cover as much as possible. So you did not bring anything on scabies. If you know other entities or something related, or desmodes infection, you can easily talk about scabies or lice. Some are that interrelated. So they bring something that we talked about, but not exactly, but it's related with what we already discussed. You can just use that knowledge to answer the question. So it's for our good. So please let's answer as much as we can, please, so that those are the participants going for exam, it will really help them. So thank you so much once again. I want to make a comment. I must appreciate the last Dr. Ekelere Betane. She was the one. She helped to share slide for Dr. Afolabi. And please, Dr. Atta is the class rep. You cannot do everything alone. So man, you're not been able to give me a class rep. That means everybody should assist him. So it should not be the ones anchoring, it's the one sharing slide, it's the one timing. I know normally we usually participate. Please, I want to encourage more participation. Encourage him as much as possible. Assist him. Before he will say, oh, it's volunteering, let like 4 hands be up. Please, let's help him. This is our thing. Please. Thank you so much. That's just my comment. It's been a wonderful day. Don't know. Chief Dr. Kopi and Chief Cookie, just a comment for the class. Let's close the class.